have an academic background in sociology and gerontology and public administration, and I've been working with people with Alzheimer's disease and their families since 1985. Um, so it's been a long career of working in aging with a specialty in dementia, uh, primarily in the area of policy and program development, occasionally um, tipping over to the world of education like we are this morning. So I'm glad to do our second Traeger presentation in 2 years, and maybe someday we'll actually be together in person. So what we thought we'd do is, since we're in the investigative track, we'd start with a little bit about what has motivated our work to investigate live-alones with dementia, not your typical dementia topic. So maybe, Laurie, you could talk a little bit about your motivation to investigate live-alones.
So I'm going to share again my screen. So my research interests, largely speaking, or broadly speaking, are in Alzheimer's and related dementias. So again, my background was more in looking at neuroimaging. So this is a picture of Pittsburgh Imaging Compound. I worked on a number of studies that were looking at a cheaper version of PIB, so like flutometamol, which is F18. So it was a radio tracer that would look at if we could predict individuals who had mild cognitive impairment who would convert to Alzheimer's disease. And while working on those clinical projects, I got to work with individuals with dementia very, very closely. I was one of the individuals that did most of the intake and neuropsychometric assessments. And it was in working on those clinical trials that I really saw a need to work and study the personal experiences of these individuals, their lived experience. And so it sort of shifted my trajectory from neuroimaging to really looking at more qualitative aspects, the home environment of individuals with Alzheimer's disease. And so if we look at the next slide, so as Mike mentioned, individuals that live alone in the community are a real interest. But for me, it's in relation to a dyadic perspective. So not only often you'll see research focuses on live-alones and it's looking at the caregiver. What does the caregiver think about the person with Alzheimer's disease? But I look at these individuals from a dyadic perspective. So I talk to actually people with Alzheimer's disease to look at their illness experience as well as disease management strategies. And the overall goal is to develop contextually appropriate social and physical environments. And then I'll talk a little bit more about this call from NIH to study this population and how that got me into my research, but we'll go back to Mike about his
So five years ago, now almost 6 years ago, the Federal Administration on Aging, which has a Alzheimer's disease demonstration grants to states program, now renamed ADPI, Alzheimer's Disease Program Initiative. 6 years ago, this program decided on 3 priority populations for expanding community level dementia capability. One was people at greater risk of Alzheimer's disease or behavioral difficulties that families face. Second were people with intellectual disability and dementia. And third were people living alone with dementia. This was an expression of policy that kind of mirrors the demographics of our country, in that the fastest growing type of household in America is an older adult living alone. So with that announcement by the Administration on Aging, people came to us as Alzpreneurs. Yeah, it's a pun, but you got it. Alzheimer entrepreneurs came to us and said, what can you generate? What do you know? What can we know about people living alone with dementia? And we've been involved in a number of community level summits, some original research projects. We are under contract to the 3 primary researchers in this space to provide content matter expertise. But I have to say, I think the driver for our team and getting involved in, there's two drivers in the team. The stories are compelling. And while I realize that data is not the plural of stories, I also believe that story and narrative has a data element to it. Our second driver in doing this is just the stories are compelling, and the need for a real community level response. As an old community organizer, it's just been an awful lot of fun to work with communities and develop community of practice around live alones. So I think uh, it's an area in which other people don't play, and we'll talk about that in a second. Laura, do you want to say any more about why we uh, are deeply involved in this investigative track of live alones?
Some of that's going to come into play with my other intro.
So let me switch over to some of the big picture data that I've alluded to so far. Most reports on Alzheimer's disease, and let me back up by saying dementia, level set here, dementia is an umbrella term. Lewy disease is one of the causes of irreversible dementia in older adults. There also is frontal temporal dementia, Lewy body dementia, frontal temporal dementia, and some very rare disorders, as well as vascular damage that causes the memory loss, the confusion, the disorientation of time and place that the word dementia is intended to capture. So when so far, I guess I would use the word dementia as the all-inclusive term, understanding that biomedically and scientifically, many things may cause dementia in older adults that is irreversible. But when we look at the data, here's some things to think about. Most reports on Alzheimer's disease and related disorders in the United States have a line in them that says 20% of people with Alzheimer's disease live alone, and it stops there. There's very little curiosity, there's very little descriptive or other information in most of the facts and figures types reports or prevalence reports about Alzheimer's disease. And that's kind of 20% is a big number. This is also so that's one big picture number of the data on live alones. I think, secondly, and Laura will alluded to this, the dominant narrative about Alzheimer's disease in this country, in addition to being a tragedy narrative, that the brain robbing, mind robbing disease. I mean, you see these kind of descriptions of Alzheimer's disease that people living with dementia just abhor. They hate them. In addition to the tragedy narrative, everybody has a caregiver. We are a dyadic picture of Alzheimer's disease. And in fact, for many years, the Alzheimer's Association, and by the way, 23 years with the Alzheimer's Association, still work with them on their public health efforts. But for many years, the Alzheimer's Association logo was a person with dementia leaning, literally leaning on a caregiver. It was dramatically, physically representing a point of view that all persons with Alzheimer's disease must have a caregiver. And that's just not necessarily true. The live alone problem, in addition, is part of a greater big data problem when we talk about Alzheimer's and dementia, and that is underdiagnosis. In the United States, we believe that only about 40% of people living with Alzheimer's or a closely related disorder have a actual diagnosis in their medical record. Of that 40%, a third have not had that disclosed to them. So it's very possible that some of the live alone with dementia people are those that are either un or underdiagnosed or to whom that diagnostic information has not been disclosed. It's a troubling issue that many people have been working on, but it is something to think about. We think live alones are a couple of other data points. We think Live alones are probably disproportionately found in senior housing. That's why many of our outreach efforts involve the American Association of Senior Housing's service coordinators. In addition to that, there are uh, there are indications that in some markets, for lots of different reasons and lots of different stories, persons who identify as LGBTQ are disproportionately in the live alone category. And one simple way to get a fix for a community organization, if you represent a community organization and you're curious about outreach to live alones, one simple way we've found is to actually take census data by zip code and look for uh, high prevalence of single person households over age 65 by zip code. It's a quick way to, if you're analyzing a city the size of Louisville, for example, it's a quick way to find where some of those pockets of people with dementia might be living alone, even if they are not diagnosed. So I think that's some of the big picture data about live alones. We're monitoring the chat, and I'm just going to take a quick look. Mr. Splaine, what do you think might be the best data point to gather today to make a positive impact? How do we get in front of this? Whoa. Can we come back to that maybe? It's not immediately relevant, but I will ponder that and we'll come back to it. But let me just offer one story of two stories of precarity and marginalization. Elena Portocolone from the University of California, San Francisco, along with Laura Gerling, are the two. Sorry, there somebody's microphone is open and it was just disturbing for a minute there. Are two important researchers in the field, and thank you, whoever that was. Thank you. Um, Elena wrote a seminal paper about live alones called The Precarity of People Living Alone with Alzheimer's Disease. What do I mean by precarity? Of course, is a great 50 cents word, but it is in fact true that a person living alone with impaired thinking that is interfering with their activities of daily living in this hypercognitive society has some risks. It's not surprising, for example, to note that most financial exploitation of older people is people with impaired thinking. Imagine the not having somebody to live with and test some of those things with. Well, one story of precarity is this. A man who's living alone with dementia said to me, when I reveal to somebody that I'm living alone with a diagnosis of dementia, it's what that other person thinks that means that disables me. Because I'm going to live a long time with dementia. And in fact, most people live 4 to 8 or as long as 10 years after a formal diagnosis of Alzheimer's disease. There's a lot of living with impairment, and it's a gradual, slow, insidious process, but it's a slow process nonetheless. What people think dementia means disables me. That's a rights-based approach. That's a different kind of way of thinking about it. And the story of precarity is this. One of the things we have done as a company is we have put on, and hopefully now that we're mostly past COVID, we're back in the business of convening with community agencies, community level summits on living alone with Alzheimer's disease. And at one of these summits in St. Louis, as we do, we had a person with Alzheimer's disease who's living alone as our first and keynote speaker. As she started speaking, a young man from the audience found me in the back of the room and asked me for details about our speaker, where she lived, how she got to our meeting, everything I could possibly know about her, because he represented the local aging and protective services department, and he was determined to open a case. I encouraged him to think about what he was talking about and to listen to this woman and to understand her story before he automatically assumed her to be unable to make her way. But think about an organization, an agency with the powers that Adult Protective Services has, that has a thimble full of resources, that was ready to jump in on the assumption of disability. This is one area of precarity that people with Alzheimer's disease who live alone. Marginalization, particularly uh, particularly painful uh, in the last 3 years of COVID. But the thought that this is not an easy life, but I want you to also take away from this that there's a lot of living with dementia long before people are completely disabled from it. And I think that's just an important point to think about when we start talking about live alones. So big picture data, I think we've satisfied that for the moment and given you one story of precarity. One other story of precarity that's becoming very clear is that people who live alone with dementia, who for whatever reason end up in the hospital, are at great risk of losing their housing. And this is coming true as we're working more and more at the community level with care transitions programs because bills go unpaid, mail goes unanswered, and people have nowhere to go when they are discharged from the hospital. This is particularly true in urban areas, but we're starting to see some of this in rural areas as well. People, just one other area of precarity, imagine a hospitalization leading to you losing your home or losing your apartment, another area of precarious living for people with dementia. So that's some of the data. I think it's now time for Laura to switch over and present her findings.
Thanks, Mike. Your work is really wonderful, and we'll see if I can get my. So let me know when I hit screen share. I'm going back now. Can
You're
you
there.
see? Can you see one single large slide?
Yes.
Okay, you don't see two slides?
Well, it's a red line and
Okay, that's
something to
fine.
the right.
So it's again,
All
as
right.
soon as I hit screen share, I don't see anything. Okay, I see like a double screen. Anyway, so I've been fortunate enough that I've been funded by NIH for 3 ongoing projects. The BioAD study, which is looking at ethical research inclusion of individuals who live in the community with dementia. We know that individuals with Alzheimer's and related dementias are some of the most excluded groups in society. They're often included in clinical trials, but we look at other more socially oriented studies. It's often if they have cognitive impairment, and definitely dementia, they're excluded. It's an exclusion criteria. So with that study, we're looking at developing models for ethical research inclusion of this population, balancing things like risk and autonomy. The COVID-19 study looks at caregiving during COVID. So looking at how individuals with Alzheimer's and related dementia and their caregivers, how they navigated the pandemic. Now, the study that I'm going to focus on today is the ADLA project, which is specifically looking at individuals with Alzheimer's related dementia who live alone in the community. So they don't cohabitate, they don't live in an institutional setting like assisted living. So they live alone in the community. So I'm looking at, for this presentation, it's a select area. As you'll see from some of the later slides, this is quite an extensive study in terms of the narrative data that has come through. So for this presentation, we're looking at a subsample. So we're looking for this at individuals who live alone in the community with Alzheimer's, and specifically at the subsample who lack a family care option. So no blood relations or marital relations that existed, and I'll talk more about that. So always want to say no conflicts of interest. We're grateful to NIA for funding our work, and as well as grateful to the study team who were part of our analyses. You'll see from the future slides that we have thousands of pages of narrative data. So this takes many people going through coding, sorting through. So always thankful to the analytics team. So a little bit of background, and Mike touched on a number of these factors, so a little bit repetitive. So we know that this is a little bit dated. There are more than 55 million individuals who have Alzheimer's and related dementias. Now, I work with a number of gerontological or gerontology students and other people in the field of gerontology, and it's amazing because many people think when you say dementia or Alzheimer's disease that this equates directly to institutional settings. These people cannot be living at home. They cannot be living in the community. Well, we know that about up to 70% of individuals with Alzheimer's and related dementia, they actually reside in the community. So it's a smaller percentage that are in institutional settings, depending on the study that you look at. Now, what's surprising, and Mike touched on this as well, is that a third of cases live alone. And Mike mentioned that usually in reports it just stops there. They mention that people with Alzheimer's disease, live alone, and there's no further analytics based on it. We're going to talk more about our analyses relating to this, but so Mike touched on this as well. So if you look in the literature, you'll see that most studies focus on family caregivers. 90% of literature focuses on typically the spousal dyad, or maybe looking at an adult child, usually the adult daughter. And there is this presumption across academic domains that everybody has some type of family support. Everybody has somebody to support them. Now, the Alzheimer's Association does estimate between 30 and 50% of individuals that live alone really have no familial caregiver, no family that's available to provide them any type of assistance, which I think some people are very surprised about. So here, this is what I was touching on earlier, that the Dementia Care Summit several years ago touched on the nature of what are the informal care options among live-alones with Alzheimer's who lack these consanguineal and affinal relationships, so the blood relationships as well as marital relationships. So people that don't have these resources available, what type of informal care do they utilize? So this is touching back on this larger project. Now, for this larger project, we did not just focus on individuals who did not have a family care option. It was part of the data that we saw, which is then part of the sub-analysis. So with this larger project, it was, if we're talking broadly about methodology, it was qualitative descriptive. Again, we focused on these dyads. We looked at individuals with Alzheimer's disease, as well as a study partner. We call them a collateral. Data collection, multi-component. So we did in-depth interviewing. I have semi-structured here, but I think a more adequate way to describe it would be in-depth interviews. Our interviews lasted about an hour and a half on average. Now, some of the interviews could have been up to 3 hours, and we got some really, really great information across many domains. And here's just 4 pertinent domains: illness experience. We talked to the individuals about what it was like to have dementia, what was the diagnostic process, prognosis, etc. How are they managing their disease? What support systems are available? We also talked about long-term care planning. Do they have any plans in place? We conducted home tours of their physical home environment, looking around at, are there any hazards? We looked in their refrigerator, do they have food? We looked at different aspects of their home environment. And then the individual that was in the home doing the in-depth interviews and the home tour was taking detailed field notes about their observations. We also did some psychometrics, the Clinical Dementia Rating Scale, as well as the MoCA, the Montreal Cognitive Assessment, as well as typical for NIH projects, we collected standard bioform information. So for that larger project, inclusion criteria was, we weren't looking at individuals who had early onset Alzheimer's disease. We had an age criteria of 65 and older. They had to have a diagnosis of Alzheimer's disease with mild severity, community dwelling. Community dwelling, again, is no cohabitants and not an institutional setting. Reside alone. They also had to be able to pass an evaluation to give consent. Now, the evaluation to give consent, we use Barbara Resnick's standard measure, which looks at if the individual can tell you, what they're going to engage in, the risks, the benefits of engaging in the research. For the collateral, they had to be an adult. had to have regular contact about at least once a week, and the individual with Alzheimer's disease had to rely on the individual for assistance. So these are general recruitment. So this is again dated. We have one individual who's out in the field now collecting additional information, and that has not been populated until into this recruitment and screening visual. But this just gives you a sense of sort of where we're at. Again, these are ongoing projects, so we're continuing. So around a little less than 200 screened. You can see individual Alzheimer's disease, 125. We largely, in terms of individuals who have been interviewed, we've had largely females. AA is African American, and HW is non-Hispanic white. You can see that we're lacking at this point in the male category. So again, our recruitment efforts are in this area trying to amplify. And you can see if you look at ineligible or not interviewed, we have a number of reasons why some of the individuals that were screened did not quite make it into enrollment. So some of the highest is that many people did fail the evaluation to give consent. And there were, if you look at the bottom, there are some people that passed away before we were able to interview them, or in fact, when we went to their residence to do the initial screen, they did actually cohabitate. So study partners, again, this is true to what we see in the literature. Most of the individuals who were study partner or collateral tended to be female, and there were 7 that we were unable to schedule. So just to give you an idea of what we did in terms of data processing, and I don't know how many individuals are familiar with different programming, but we used Atlas TI or are using Atlas TI. So what we did is we had the narrative professionally transcribed, and then that narrative was uploaded to Atlas. And what's really nice about Atlas is you can anchor the audio file with the text. So you could be reading through, and this is just a sample of a visual of what it would look like. You could be reading through the narrative that the person with Alzheimer's disease, the narrative between the interviewer and the person with Alzheimer's disease, and then click on that narrative and listen to how that information sounded, because reading something is very different than listening to it, especially if you're doing analyses. So for example, you could get an idea whether the person said something in jest, or if maybe there was anger in their tone. You can get additional information about that narrative by listening to different segments. So this is just a little bit of information about what we did. We anchored the audio and the narrative. So over a 6-month period, we created a code book. And we used 50 interviews, and we iteratively tested it. We had inductive codes from the data as well as deductive codes that we thought were going to be pertinent just from prior literature. We came up with around 62 codes, and we used Atlas intercoder agreement module to calculate, and we came up with basically 41 codes that had inter-rater reliability that was sufficient for the protocol. So we had 41 codes. Those codes were then applied to all the narrative in rotating pairs. So this is just sort of an example of what it looks like. So I mentioned that the analysis that I'm talking about today is a sub-analysis of the larger projects. What we did is we filtered by all individuals who had no family, but did have a study partner, so a non-blood relative, a non-marital relative that did sign up to be the individual's collateral or study partner. So that was almost 2,000 pages of narrative, which is quite substantial. And then we pulled from the code of the data that was coded in formal care support, which then filtered us down to 264 pages. So we use standard content analysis. I think I'm running low on time, which is ELOs. This has been cited, I think, several thousand times. The standard content analysis can be viewed here. Rigor, what did we do in terms of rigor? We have one of the nice things about Atlas is there's an audit trail of your decisions and coding, so you can go back through and somebody could technically replicate what was done in terms of your analytic decisions. Paired coding also increased the rigor, so this wasn't just one individual. This is 8 individuals rotating pairs using this codebook, and the intercoder agreement increased the rigor, and also descriptive approach also increases rigor in that there's really little inference with this type of research. We're using the direct words of the person with Alzheimer's disease, which helps to establish credibility. There's really low projection about your own findings. It's actually the direct words of the individual. So again, as I mentioned, this is ongoing. So what are we seeing preliminarily? So here's just some descriptive stats. So our sample is around, at least for this subsample, almost 82 years old on average. Now what's interesting, if you look here, is the study partners are around 76. Right? So the study partners are older adults as well, the individuals providing care. So around equal, both had around a high school education, and you can see the gender as distribution here as well as race and ethnicity. And I do want to mention that based on the way that this study was funded through NIH, we only looked at African Americans and non-Hispanic whites. And as well as you can see marital status here. So most of the individuals were actually widowed. So who are the study partners for these individuals? Largely friends, neighbors. So friends over 50%, neighbors 30%, and other. So people that don't meet that category. So for example, we categorized one individual that was the goddaughter, and that was the individual's friend's daughter. So no family relation in terms of blood or marital ties, and also again didn't fit nicely into the neighbor or friend category. So there are only 16% would be 3 because of the subsample was 19 friends, so that would be 10%, neighbors 6. Okay, so what did we see in terms of that thematic analysis? So here, what we saw was this idea of transient informal care. So informants described having at least one individual who provide ongoing assistance. Now, the type and intensity of care vary greatly, but all informants receive some type of tangible or instrumental or emotional support from a non-family caregiver, so that collateral. However, this support was portrayed as transient, so deteriorating health of the informal caregiver or this weak investment and the confines of non-kin ties were cited as primary reasons for care transient. So you can see here, the individual says he's going to need more help than I'll be able to, more of a physical assistance. I have my own issues taking a toll. When his physical need gets worse, I won't be able to provide care any longer. So the reason for here, you can see the individual says that their caregiving is only going to be temporary for the individual with Alzheimer's disease. It's because their own physical health was deteriorating. And we saw this too in the slides too before, that most of the individuals were older adults themselves that were providing care to these individuals with Alzheimer's disease. Weak investment. So here an example was, I did it until the end for Amy, but I couldn't do that here, not that kind of relationship. She'll have to go to a home. So this individual was providing care to the person with Alzheimer's disease, but described that their relationship really wasn't strong enough for it to be a long-term caregiving relationship. And this person had provided care to Amy. I believe Amy was a family relative who had a chronic condition and provide care until Amy's death. And so for Amy, this individual was willing to provide long-term care, but for this other individual with Alzheimer's disease, that there was no family connection, the person was unable to do that, is how they described it. Confines of non-kin ties. So here you can see the individual just provides a description and talks about how they're happy to provide care now, but once the person really needs some type of bodily care, that I'm not doing that. That's more for somebody like a daughter. So this is in their words, that no, I wish she had a daughter that would do that, because at this point this individual was a friend, and they said, well, that kind of goes beyond the friend relationship in terms of caregiving. So we also saw consequential peripheral ties. So despite the absence of family relations and express transience of available informal care networks, narratives were really, this discussion, we had hours and hours of discussion. They were laden with discussion of relationships, of these consequential peripheral relationships that were really important to daily functioning. So this could be people like local service professionals, local merchants. There was also some discussion about these virtual connections. So if you look here, we separated them to two, in-person and virtual. So in person, the description here is the mail carrier was extremely important to one of the individuals with Alzheimer's disease. This person would sit on their porch daily and would see the mail carrier. The mail carrier sort of served as a wellness check. They knew the individual there was something wrong if Miss Mary, as you can see here, was not sitting outside. So even though the mail carrier was, again, more peripheral to their care, it still was a consequential relationship to the individual. Virtual, we saw that bereavement groups, some of our participants were a part of bereavement groups that were very, very important to their connections. So even though that these type of virtual connections didn't provide like tangible care, it was care and support in a different way, more virtual, but they were these really, really important consequential peripheral relationships. So the third theme was this idea of the detriments of uncoordinated care. So those peripheral connections that I described in the previous slide were very beneficial to informants' functioning. But it's important to note that those peripheral relationships, most of those people did not know each other. They might have had several peripheral relationships, maybe somebody from the grocery store, somebody from the mail carrier, as well as maybe a neighbor. So they might have had a number of individuals that were part of their care relationship, but those individuals didn't coordinate. So what does that mean if you have people that are part of care that don't coordinate? So you can see in these descriptions here, there was one informant that had 2 or 3 individuals, friends, who were providing care with medications. Well, they didn't coordinate, so this individual was getting too much medication. And this happened on more than one occasion across multiple informants, to the point that some of these individuals were hospitalized because of medication errors. So why is this important? Again, as I mentioned previously, most research does focus on family care relationships, but again, there's this assumption that most people have family. Well, this is not true. Now, if we look at the literature, there's really only 5 to 10% of studies that focus on unpaid, non-professional, non-kin support. So really, there's a gap in the literature that needs to be continuously filled. Now, what we did see is that non-family relationships that we saw within our collaterals, they did act in a compensatory manner. They did take the roles that would traditionally be seen in dementia care in many, many ways. However, as you saw within the themes, that friends and neighbors are, again, they're more voluntary. They're not bound by those family obligations, as our participants discussed. So, when it gets to a certain level, individuals would indicate that the care relationship would end at their convenience. I'm not willing to go this far for this individual in terms of caregiving. And also something that's important to note from this research too is that these non-kin relationships are often, we see in the literature, nurtured by reciprocity. What can you do for me? What can I do for you here? Well, in individuals with Alzheimer's disease, there's a lack of reciprocity. So a lack of reciprocating and helping in many ways. And so some of the collaterals saw that as being potentially problematic for these long-term caregiving roles. And again, so we touched a little bit on the informational exchanges and informational platforms, and this is something that we're going to delve further into, and I think is going to be really important for this live alone population, looking at these virtual exchange platforms. So some quick limitations. So again, this is ongoing protocol. It's not the full data set. So things might shift a little bit as we continue obtaining data and furthering our analyses. And again, this study was not designed to look specifically at non-familiar relationships. That's just the way it panned out within the first few years of recruitment. And again, the sample that we have really isn't large enough to look at differences, whether it's sex or race differences. We did exclude individuals that did not have a study partner, and it would be very, very interesting to look at analyses for individuals who did not have a study partner. I think that their narrative would be very, very different. And also we did only sample from one geographic region. So I have another slide relating to sub-analyses, as well as NIH funding, but we can kind of go into there if maybe people have any questions. I always encourage individuals who are interested in Alzheimer's disease and Alzheimer's research to look at things like funding lines. This is funding lines from fiscal year 2022. The current fiscal year is not quite as good as these funding lines, but if you do have an application or are really interested in Alzheimer's research, now is the time to submit, because really, we've seen, we don't see funding lines like this often. Mike, I can see you now. I made my screen smaller so I can see another. Yeah, this is a rare opportunity for anybody who's interested in Alzheimer's research to potentially gain funding. Again, if you're an early stage investigator, so somebody within 10 years of your degree, your funding lines are phenomenal. So submit something, you'll get feedback. But if you are interested in not even just live alones, anybody with Alzheimer's disease, regardless of sort of the subtopical area, now is your time to, maybe look into an application. Yeah.
Or look into a collaboration.
Yeah.
So let's take a minute and see if there are any questions specific to the ADLA presentation that Laura just made. There's no more posted in the chat. People can open their microphone and ask a question if they wish, or put something in the chat. Well, hearing none, let me go into our last block and pick up that question that was in the chat. I respect researchers and I work with researchers, and I could even say some of my best friends are researchers. I'm more of the practical guy, and so what I'm about to present is what we've learned from our engagements over the last 5 years, particularly our community summits and our development of and supporting an online community of people living alone with dementia. And the first thing I would just point out is that the demographics here are inescapable. It's how we live. And as a baby boomer, I was born right at the midpoint of the baby boom. Twice as a grammar school student, I had this thing called double sessions. I went to half a day of second grade. I don't know what I didn't learn because they brought in a second shift. The schools were filling so quickly they couldn't keep them built or staffed because there were so many baby boomer children. This is the same kind of demographic, folks, and the demographic destiny here is inescapable. Many social service organizations who have attacked or tried to get involved with live alones have worked with the most difficult cases and the people that are completely bereft and unbefriended. And a strategy for a community agency that we've seen is more effective is that in addition to building a structure in the community for the unbefriended and the most tragic and difficult cases, they also need to work upstream. They need to take a public health or a preventative approach. And that's where looking at their community, for example, zip code data, convening community summits might be helpful. At the individual level, we think the most successful people living alone with dementia are those that are planful. And in fact, we recommend something called Atlas of Care's Care Map as a playful way in which people can look at who they care for and who in turn cares for them, and maybe plot out some path of life that will help them live well with dementia alone. Ethical issues roll right in here, and nearly every time we've done a community summit, we've had somebody from the world of bioethics come in, because in fact there are lots of ethical questions here about when or how to take over the life of another, what the consequences are. How do we build an ethos in our community that is inclusive of people with severe thinking problems living in our communities, not just being institutionalized? Lots of ethical issues. Ultimately, solutions for solving and helping people with dementia who live alone have their best lives are community level solutions. You can't one person at a time this problem. And just before COVID, in some of our early adopter live alone clients that we were working with, we were headed down the road toward housing and creativity in housing. And I suspect that we'll get there, but some forms of group living, shared housing, or supportive housing models need to emerge if we're going to support these folks in some way. As I mentioned, we run with the help of a fine dementia professional, a online community of by and for people living alone with dementia. It's called Living Alone and Connected. It has a companion web page that we post general information on for people that are not living alone with a diagnosis of dementia who won't qualify for the group. It's a good resource. We try to post a couple times a week and try to keep people up to date on things that we would help. Last, and we're doing this with Laura as well as my business partner, Kate Gordon, and a PhD from the School of Nursing at University of Maryland. Our curiosity doesn't stop. We're going to actually go out to 5 dementia community friendly community leadership groups here in Maryland in the next few months and find out what they're thinking or doing about live alones with dementia. Are they stuck in the dyadic, everybody's got a caregiver mode of thinking about dementia when they are trying to create a dementia friendly community? Be really interesting to find out. One last, and if you're really curious about it, drop me an email. One of my brilliant young grad student associates, Tamara from UMBC, just did a paper for us that we are going to post on Living Alone and Connected about loneliness in dementia. Sometimes we forget the emotional life of people living with dementia because we're so focused on the intellectual. And it's a wonderful short essay, well referenced, that we're about to post through our mechanisms, because it's an area, loneliness is, especially as we're thinking about social isolation more broadly because of COVID and otherwise, and older people, zeroing in on understanding how and understanding that people living with dementia experience loneliness, I think will give us another clue about how to help this group of people live well with dementia. To the point that was made, what's the best data point that we can possibly have about the current and coming crisis of Alzheimer's disease in our society and other, and not just our society, by the way, 60, 70 million people around the world and growing rapidly in the lowest and middle income countries. I think the best space would be, if I were the king of the universe, I'd put a lot more attention on, and I think we will be in this country and around the world, on what can we do to lower our population's risk of dementia in late life. The risk science is finally ripe enough that we can say without hesitation that, for example, reducing tobacco use will reduce the population risk of dementia. The heaviest evidence we have, identifying and treating midlife hypertension. My point being that that's the data point we need. And to be able to demonstrate effect, it seems to me that we have to get used to the idea that cognition needs to be our 6th vital sign. I wish that was an original idea. It actually was initiated 12 years ago by a couple of VA docs. But I think just like we do temperature and blood pressure, our other vital signs, I think our thinking, measuring our thinking and keeping a record of if our thinking is changing or has changed as part of medical records, normalizing cognition as a vital sign would go a long way toward being able to solve both individual and Alzheimer's and dementia issues from a public health perspective. That's an opinion, but you did ask for an opinion. So we're both very reachable. Our contact information is in the main program information for the conference. We're glad to talk to other folks that if this has piqued your curiosity, if you want to know more about what we're doing, we're both easily reached. We're both in Maryland, but we work across time zones. And we pretty much know everybody who's active in the space. So even if you live in Waco, Texas, we probably know somebody who's been doing something about live alones, maybe in Houston, maybe not quite in Waco, but we do know a lot of the points of light about live alones around the United States. So with that, we'll come back to our host and again ask for questions in the chat or to open your microphone and have Jim guide us through any more Q&A.
Great. Thank you very, very much. That was riveting. I'm glad I didn't have to have more to do because I was paying so much attention to that I probably would have forgotten it. So you could either put your questions in the chat or you can unmute yourself and ask. We do have a survey. You should have gotten an email today, so it's important that you do that. This is available for CEUs, and filling out the survey is the way to get that kicked off. So I am not seeing any more chats. So I don't know if people are getting hungry or what it is. But thank you very, very much.
Yeah, thank you, James.
Well, it's 11:25. Nobody ever died from ending 5 minutes early, so I think we can sign off.
All right.
Again,
Okay,
people can
great.
follow up with us as they wish.
Yeah, it was nice
All
seeing
right.
you, Mike.
Have a great conference.
Thank you very much.